The following podcast is based on a recent live symposium chaired by Dr. Jorge A. Marrero from the University of Texas Southwestern Medical Center in Dallas, Texas. The podcast is part of a certified educational activity titled Surveying the View from the Driver's Seat in Hepatocellular Carcinoma, bringing into focus hepatology's key role in guiding HCC care down the path to improved outcomes. Access the entire activity and complete the post-test at www.peerview.com/WDR. Downloadable slides and practice aids are also available.
Good evening. This is a program that we're going to focus on looking at the different therapies for hepatocellular carcinoma. We have really an all-star cast. Ladies first, Laura Kulik. She's a transplant hepatologist at Northwestern University in Chicago. She's really been a force in terms of research for interventional radiology. Has how many publications? More than 100. So she's really been a leading expert in this area and working with an excellent group at Northwestern. We have Dr. Richard Finn, medical oncologist at UCLA, and who's also been doing pioneer work in ACC as well as in other tumors. But his latest focus is HCC over the last several years, so we're lucky to have him. And finally, Anthony Elqueri. He's a medical oncologist from USC, also been doing pioneer work in systemic therapy of HCC, and more recently with immunotherapy, so we're really lucky to have him. So we really look forward to, in the next hour and a half, to have a discussion. The format is going to be, each of the panel is going to give a talk, then we're going to have a case built in after their talk in order to have a discussion about key points in terms of information. And we'll hopefully make it interactive. So welcome, and let's get it rolling. So in terms of management of HCC, there are a few general principles. HCC, because the tumor generally occurs in someone with chronic liver disease, it really benefits a multidisciplinary team. You need the hepatologist to assess the liver disease, liver function. In some places they treat. You need the medical oncologist, diagnostic radiologist, interventional radiologist, radiation oncologist, and then either a transplant surgeon or even in some places a surgical oncologist. So it's really a multidisciplinary team taking care of these patients. This team will assess the suitability for different curative interventions such as resection, transplant, or radiofrequency ablation and other ablative techniques. Also, it's important to understand the indications and limitations of each of the therapies, specifically local-regional therapies. Consider the role of targeted systemic therapy, the indications, dosages, and side effects. Assess the underlying hepatitis function, the viral hepatitis status. We're fortunate that we live in an era that hepatitis C has been on the process of being cured and hopefully eradicated, viral hepatitis with a vaccine. But we have other liver diseases, the fatty liver, that are going to be a challenge in the future. And then encourage patients to participate in trials. So all of that is quite important. This is the latest WHO data in terms of incidence in blue for different solid tumors. And as we see here, in terms of incidence, liver is about number 7. And then in terms of mortality is the 4th cause of cancer-related mortality. This is from the International Agency for Research in Cancer from the WHO. So it's really a big burden. And this is the snapshot in the United States. So in terms of incidence in the United States, in the last several years, it's somewhat plateaued. This data comes from the SEER database, which assesses 20% of the US population in different strategic places. And in the SEER locations, you have to indicate any tumor and submit information about any tumor that is diagnosed in that specific area. And that allows us to get this data. So the incidence is plateauing in light blue, and then in terms of the mortality has also significant mortality. So fairly close, the incidence and the mortality. So it's still a pretty deadly tumor, even though the 5-year survival has gotten better. So a lot of it is knowing who's at risk, the diagnosis, the interventions, that I think the overall survival, especially the 5-year survival, has improved, especially compared to 15 years ago. This is the projected ACC incidence based on different modeling studies. In males, basically, it's probably going to peak around 2030 as the hepatitis C cohort that got infected in the 60s and 70s moves on. So this is the peak incidence, it's estimated, and then in women, pretty much as well. So I think for, at least probably for the rest of my career and everyone's career here, it's still going to be a significant problem. And this is what, at least in the United States, what's happening. We have, based on the SEER database, about 42,000 cases. Based on the way the SEER database described this group, about 20-25% are probably localized tumors and considered early. Transplant is probably the most important curative intervention, given the portal hypertension will limit the number of resections. So we cannot transplant everyone. So we're going to be doing more and more either aggressive resections, aggressive local regional therapies, potential combinations of systemic and local regional to treat our patients, because unfortunately we're limited with the number of transplants for ACC. This is the Barcelona staging classification. The important aspect is that this classification evaluates the tumor burden, the liver function in terms of the Child-Pugh score, as well as the performance status. And those three variables basically in a lot of prognostic studies have been shown to be very important. So the Barcelona stages, to me, this is the most important part to differentiate these patients, because they do have different survivals, like a stage A versus stage B versus stage C and D. So the Barcelona links it to a treatment strategy, but at least when we participate in the AASLD guidance and guidelines for ACC, and Laura Kulik and Rich Finn participated, we focus on the tumor staging, and then based on the level of evidence, we discuss the best treatment option. So resection for stage 0. There's no randomized trials for transplant resection and the other therapies in stage A. So you have to evaluate it. The stage B, basically, TACE is one that has the most study with transarterial radioembolization. And I'm so happy to see this stage C, in which a lot of trials, and this is the topic of today, this stage C and all these names and different therapies that have been approved and phase 3 trials, and there are more coming down the pipeline. So we're going to be discussing stage B and stage C HCC. There's still a lot of unanswered questions in HCC, but hopefully we're going to tackle some of them today with the expert panel that we have today. So we're going to evaluate the local regional management of HCC and proper patient selection, the recent options for targeted therapy with advanced HCC, and the latest advances in immunotherapy and treatment modality in patients with HCC, and then we're going to do the cases. So to further ado, I'm going to introduce the first speaker, Laura from Northwestern. She's going to talk about understanding the evidence of local regional therapy and patient selection. Laura.
Thank you very much, Jorge, and good evening. So local regional therapy has been an integral part of the treatment of HCC. And I think it's very important when you start to treat someone with local regional therapy that you define up front what your goal of local regional therapy is. Is this curative? This is generally being limited to very early tumors treated with RFA. Are you trying to bridge or downstage to a curative treatment such as transplant or resection? Or is it really palliative, where your goal is to improve overall survival with not the ability to cure patients? And this is really the group of patients that when I first see, I do talk to them up front about systemic therapy, because we know that they're eventually going to be going down the road of systemic therapy if they can preserve their liver function. The decision into which liver-directed therapy to start with is really dependent on both the patient and tumor characteristics, and I would say heavily dependent upon the experience of the center that is treating the patient. So as a transplant hepatologist, I want to remind everybody that the best treatment for liver cancer is a transplant. It removes the cancer as well as the underlying liver disease. And currently, patients who meet the Milan criteria are given an exception with a prioritization in order to get to transplant. However, those who exceed the Milan criteria are not given any prioritization. And we know that there are select groups of patients who would derive a better benefit from transplant than non-transplant options. These include patients with validated extended criteria, patients who are successfully downstage, and patients who have BCLC-D related to severe liver dysfunction. Recently, the guidelines have been updated for both SSLD as well as EASL, and both endorse the use of bridging therapy as patients are awaiting transplant with the goal of decreasing the rate of dropout due to tumor progression. Additionally, they both state that consideration for liver transplant should be done in patients who are successfully downstaged with local regional therapy to the Milan criteria, specifically taking into account only the viable portions of tumor when accounting for the tumor burden. I'll now talk about an overview of liver-directed therapy, and we'll focus only on intraarterial therapy. You're all familiar with chemoembolization. This takes advantage of the hypervascular nature of HCC. Chemotherapeutic agents followed by embolization agents are injected into the hepatic artery supplying the tumor to induce necrosis. Based on randomized controlled trials, this has become the standard of care in patients with intermediate HCC. Complete necrosis occurs in about a third of patients, and greater than 50% of patients will develop symptoms of fever, nausea, vomiting, abdominal pain, known as the post-embolization syndrome. And this is not for every patient. In patients who have very decompensated liver disease, or if there's compromise of the portal vein, specifically if there's portal vein thrombosis, either bland or tumor, if there's a hepatofugal flow or the presence of the tips, there is strong concern that when you embolize the hepatic artery that you can induce severe ischemia leading to liver failure. So these are the societal guidelines. As we said, this is the standard of care for intermediate patients who are not considered surgical candidates. It is not recommended in patients who have metastatic disease or portal vein invasion or decompensated liver disease. Getting a little bit more into the granularity of the contraindications, what represents decompensated cirrhosis? These are patients generally Child-Pugh B greater than 8, although some would argue it best is in patients who are Child-Pugh A. Patients who have jaundice, SBP, refractory ascites, hepatorenal syndrome, these patients do not do well with liver-directed therapy. We've also discussed that any kind of portal vein invasion is a concern, and looking at relative contraindications, tumors that are greater than 10 centimeters, and this is generally because you're unlikely to perform segmental TACE, which is generally up to 2 segments. And then other factors, if there is a stent across the papilla, there's concern for inducing an abscess. This is not unique to chemoembolization. This is seen in any local regional therapy that induces necrosis in the tumor. In fact, the highest risk is seen in patients who undergo RFA who have stents across their papilla. So radioembolization is another form of intraarterial therapy. It differs from chemoembolization in that it is microembolic. There are microspheres that are loaded with yttrium, which is radiation. These are 25 to 30 microns. They're injected into the hepatic artery, and due to the small size, these microns become trapped within the capillary bed of the tumor and induce necrosis from the radiation. Due to the fact that it is microembolic, as you can see on this angiogram pre and post, the hepatic artery is maintained, which has allowed for it to be safely administered in patients with portal vein thrombosis. Prior to administration, patients do need to undergo a staging angiogram, generally a week before, in order to identify variant anatomy so that you don't deliver radiation to off targets, such as the stomach, the gallbladder, the colon, and also to determine that there is not a prohibitive degree of pulmonary shunting. This highlights the potential complications of radioembolization. These can be avoided by doing a proper angiogram, again identifying non-targets so that these do not deliver radiation and embolizing as needed. Identifying if patients have too large of a shunt and they're not candidates for radioembolization. A big fear is radiation-induced liver disease because there is no known treatment, and this is best avoided by patient proper selection, performing selective or super selective infusions when possible, and avoiding whole liver treatment with radiation. There has been a growing experience with radioembolization. This represents some of the largest single-center studies. These are all non-randomized. The most promising came from the Milan group, where you can see the majority of the patients were Child-Pugh A. It became clear in patients with portal vein thrombosis that prognosis is directly related to the degree of portal vein thrombosis. In patients who are Child-Pugh A with branch portal vein, median overall survival was 17 months. This diminished to 9 months in patients who had main portal vein thrombosis. Drug-eluting beads represented an advancement to conventional chemoembolization. These beads serve as the embolizing factor, and they're loaded with doxorubicin. And this allowed for a longer dwell and a higher amount of chemotherapy that is delivered to the tumor, and simultaneously decreasing the systemic absorption. You can see here in drug-eluting beads, there's a blip in the serum of doxorubicin as opposed to a surge that you see in patients who receive conventional chemoembolization. And not surprisingly, in drug-eluting beads, this has led to a decrease in systemic toxicity. Precision was a phase 2 randomized controlled trial directly comparing conventional chemoembolization to drug-eluting beads, with the primary endpoint being overall response. And you can see here in the blue and the orange that this did not meet its primary endpoint. However, when they did a post hoc analysis and looked at patients who were generally considered more ill, so patients who were Child-Pugh B, had bilobar disease, who were ECOG 1, who had failed prior therapies, they did see that there was a significant improvement in response rates in patients who were treated with drug-eluting beads. This highlights the improvement that we've seen with overall survival in patients treated with chemoembolization since the seminal trials in 2002 that showed that there was an improvement in overall survival. This is due to better patient selection, use of super selective chemoembolization. Many people feel you should only perform chemoembolization if you are only doing up to 2 segments. And the most promising results have come from the Barcelona group, which was a prospective trial of all Child-Pugh A patients, and the median overall survival was 47 months. This highlights a robust amount of research that has been done comparing drug-eluting beads to conventional chemoembolization, including randomized controlled trials, and why the systemic toxicity is clear that it is less in drug-eluting beads. There has not been a clear superiority in terms of overall survival in drug-eluting beads compared to conventional chemoembolization. So now let's move into how do we assess patients' suitability for local regional therapy. As we heard from Jorge, we are not dealing with just one disease state. It's not just the underlying HCC. 90 to 80% of patients have underlying cirrhosis when they're diagnosed with HCC. Therefore, they have a competing risk of dying of decompensation from their cirrhosis and at the same time of progression of their cancer. This represents the Child-Pugh classification, which has been in use since the 1970s. And I will point out that in patients who have Child-Pugh C, their risk of mortality within 1 year without having underlying HCC is 55%. Additionally, patients' performance status, or known as their ECOG, is found to be prognostic. So when looking at treatment for patients, it's important not only to take into account tumor burden, but also their degree of liver dysfunction and their performance status. A new kid on the block to assess this has been what's called ALBI. This is fairly simple. This takes into account the albumin and bilirubin level, both of which are part of the Child-Pugh classification. It's very simple. You take the albumin, you take the bilirubin, you see where they cross over, and you then see if someone is an ALBI grade 1, 2, or 3. I think the biggest benefit of using this, besides its ease, has been that in patients who are Child-Pugh A, as shown here, there's a clear distinction and grade 1 and grade 2, where you can see the median overall survival is significantly different. And this has been looked at in resection, systemic therapy, as well as local regional therapy, showing that there is a difference between grade 1 and grade 2. These are scoring systems that have been designed with the goal of trying to find out who is the optimal candidate for performing chemoembolization. In the BCLC substaging, B1 patients had excellent median overall survival after undergoing chemoembolization at 41 months. These other scores are also being used, and in patients you can see that as their score increases, their median overall survival decreases, which begs the question if these patients should stage migrate and start systemic therapy without undergoing local regional therapy, barring that their liver function would tolerate that. Similarly, there's been a hope to optimize and identify the candidates for radioembolization which would derive the most benefit. It has been found that there is a tumor threshold of greater than 205 gray delivered to the tumor that results in improved response rates as well as overall survival. In this very small group of patients with portal vein thrombosis, you can see those who had a boosted radiation above 205 had a significant improvement at 21 months compared to those who were below this threshold at 5 months. However, not all patients will be candidates for boosted radiation due to concern that you can induce liver toxicity. This has been seen in patients who went to the dose of radiation to the non-tumorous tissue exceeds 120 gray. And this can be calculated using the MAA and/or a PET scan prior to delivery of radioembolization, and also if the target volume is greater than 70%. In combination with boosted radiation, one can also use uptake on the MAA scan. Here you see the tumor. You see it nicely correlates with uptake on the MAA scan, whereas below, the tumor is nowhere near where the MAA uptake is. So if you combine the ability to boost radiation with uptake on the MAA scan, this designates a good candidate for radioembolization, and all others are considered poor. And using this stratification, specifically looking at patients with portal vein invasion, those who were designated as good had a median overall survival that was 17.5 months compared to those who were considered poor candidates, where you can see it significantly dropped to 3.5 months. Now, Mazzaferro and colleagues have designed this prognostic scoring system in patients who are treated with radioembolization with the presence of non-main portal vein thrombosis. It is made up of 3 components. The degree of portal vein thrombosis, again, main portal vein was excluded. The tumor burden with the cutoff being greater than 50%, and the bilirubin level with the cutoff being greater than 1.2. And patients were giving points for each of these characteristics. You can see that this nicely stratifies out based on the number of points, looking at overall survival. In patients who had 0 points, their median overall survival was 32.2 months. However, in patients with greater than 3 points who would be considered dismal prognosis, their overall survival diminished significantly to 7.8 months. Also, within 3 months, based on this score, you can see that there was an increased risk of tumor progression as well as liver decompensation after treatment with radioembolization. So the question is, when should we transition from local regional therapy to systemic therapy? And I don't have a specific answer to this question, but I did come up with some slides that I think begs the question as to when we should consider this. And this is very relevant now. We're going to hear from our 2 additional speakers of the exciting new developments that have happened to systemic therapy. I won't belabor this point because you're going to hear this, but there are first line as well as second line. As of yesterday, Pembro just gained approval in second line, so hot off the presses, we're seeing more and more agents that are coming to market. When looking at the resource trial, I thought this was important. These were all Child's Pugh A, and Child's Pugh A is a 5 or 6 points. And when you looked at the hazards ratio, there was more of a benefit in patients who were a 5 compared to a 6. Suggesting that the better your liver function at the time of initiating systemic therapy, the better overall survival. Now that makes sense. It's difficult to discern why patients' liver function is diminishing. Is it due to their underlying liver disease? Is it due to the progression of their tumor? Or is it due to the local regional therapy that you've administered? You will hear more about an exploratory analysis looking at patients who progressed on sorafenib and were started on regorafenib. And those patients, they had an overall survival using this combination of 26 months compared to 19.2 months in those who were in placebo. Again, suggesting that we need to really consider starting systemic therapy at a point where patients are going to be able to derive benefit. Some of the considerations that I think are important are what defines taste refractoriness or taste failure? And this generally in the literature has been deemed if you do not have a response after 2 tastes, that this is someone who has failed and you should consider moving on to a different therapy. There has been a real-world study looking at this called Optimus, and basically they showed in a large cohort intended to see what happened after you kept giving chemoembolization, that only 27% of the patients, once they were deemed taste failures, were able to go on to receive systemic therapy, suggesting that there's overuse of liver-directed therapy and that patients are developing liver dysfunction and therefore they're not able to go on to get the benefit of systemic therapy. The other thing is the pattern of progression. The Barcelona group reported about 4 years ago that pattern of progression matters, and this has also been shown in the study in regorafenib, that in patients who develop new extrahepatic lesions or new portal vein invasion, those patients have less of a survival than if you're progressing within the liver with a new lesion or a prior lesion. Again, suggesting that patients should be started on systemic therapy before they develop evidence of metastatic disease, and many people will not consider systemic therapy until there's metastatic disease and will continue to treat intrahepatic disease. And again, as a transplant hepatologist, I think it's very important to always be considering, is this patient otherwise a candidate for a liver transplant? Now with DAA therapy, we're more aggressive in considering transplant because patients are not dying with post-transplant hepatitis that we saw in the past. And I think with lenvatinib, which reported a 41% response rate, it remains to be seen if this could be combined with local regional therapy to achieve higher rates of downstaging. I would say also as a hepatologist that I do have concerns that as systemic therapy is coming more to the forefront and earlier, that in any patient who is potentially a liver transplant candidate, that if they receive immunotherapy, that could be detrimental for their transplant candidacy. So let's look a little bit at combining local regional therapy with systemic agents. There's biological plausibility for this. We know that when patients undergo embolization that we see a surge in angiogenesis, and this surge in angiogenesis drives tumor growth and risk for metastatic disease. So it makes sense that if you use something like a VEGF inhibitor or TKI, that you could blunt this angiogenesis and therefore potentially improve response to chemoembolization. This has been looked at in a variety of ways. Most of the studies have been done specifically looking at taste as opposed to Y90. So you can do your intra-arterial therapy and then start sorafenib, wait 7 to 10 days, whatever you decide, then do intra-arterial therapy and then restart sorafenib, or do this in a continuous fashion. It's obvious that you need to administer the sorafenib in a timely manner so that you get the benefit of blocking the angiogenic flare. So there have been several large randomized controlled trials that have looked at the combination of chemoembolization plus a TKI compared to TACE alone in patients with intermediate HCC. And unfortunately, none of these met their primary endpoint, which was mostly time to progression and overall survival. But I do think we learned some lessons from this. The timing of sorafenib in some of these trials was weeks to even months after they underwent chemoembolization. The dose and duration tended to be shorter than what we saw in the pivotal phase 3 trials with sorafenib. Some of the trials ended earlier based on the results of other trials, and study designs were conservative due to concern for safety with this combination. However, very recently there was a report of a phase 2 called the TACTICS trial, with the PFS being significantly longer in patients who received TACE plus sorafenib compared to TACE alone. Now this had a very unique study design. Patients were allowed to stay within their randomization treatment despite the development of new intrahepatic lesions. This led to longer durations of sorafenib with a median of 38 weeks, which is numerically longer than what was reported in these negative prior trials. The overall survival remains to be seen, and if this does improve overall survival, this would be some data suggests the role of combination therapy in intermediate HCC patients. There's a flurry of ongoing activity looking at combination of checkpoint inhibitors after resection, after RFA, combined with TACE, TKIs. These results are anticipated. One of the first combination trials that was reported in the literature was looking at the combination of a CTLA-4 antibody after subtotal TACE or RFA. So this study was not intended to use local regional therapy to try to kill all tumor. What they wanted to do is treat some tumor with the hope of expressing neoantigens, then therefore with the thought process that the CTL4 would be boosted as a result of seeing what it needed to go after. The median overall survival was 12.3, and they biopsied untreated local regional spots and found that the CD3 and CD8 were increased, suggesting what's known as the abscopal effect. This was a phase 1/2 trial with DARVA and the CTL4 antibody. You're going to hear more about this in the upcoming talks. This was presented at ASCO. It was found that the combination resulted in 25% having an overall response. This was higher in uninfected viral hepatitis patients, and this has led to a phase 3 trial called the Himalaya Trial, looking at this combination compared to sorafenib. This highlights many of the ongoing trials looking at immune checkpoint inhibitors combined with other immune checkpoint inhibitors, TKI, c-MET, et cetera. So again, a lot of potential clinical trials that patients can be enrolled in. Not only are they looking in a combination, but also looking at it in combination with local regional therapy, including radioembolization, drug-eluting beads, RFA. Again, a lot of opportunities for patients to enroll in clinical trials. This is one of the combination trials that has been reported and not in full manuscript yet. This was a ceramic trial. This was using resin beads in patients with advanced non-operable HCC. Sorafenib was combined with radioembolization and compared to sorafenib alone. This failed to meet its primary endpoint of overall survival. A post-hoc subanalysis did identify groups of patients who did appear to have improved overall survival with the combination, including those who were younger, those who had NASH, and those without cirrhosis, which tends to be the minority of patients. Increased AEs were noted and seen in patients with combination therapy compared to sorafenib alone. So I would summarize in terms of local regional therapy, what you decide to use is dependent upon the tumor and patient characteristics as well as institutional experience. Chemoembolization continues to be the standard of care in patients with intermediate HCC. Drug-eluting beads has been found to be safe in patients with more advanced, more ill disease. Radioembolization has been found to be safe in patients with portal vein thrombosis, but not found to be better than sorafenib with negative trials compared to sorafenib. And when you should switch from local regional therapy to a systemic agent, I think at this point in time is continuing to evolve and is an individualized decision. I would say, again, as a transplant hepatologist, I would really want to know if this patient is a transplant candidate and not abandon local regional therapy too soon. And in patients who are not transplant candidates due to comorbidities, age, wishes to not undergo transplant, that may be transitioning to systemic agents even earlier is a potential option. And with that, I will hand it over back to Jorge.
Thank you, Laura. So you can take a seat, please. So basically, we'll do the first tumor board case review from LRT to systemic therapy. So this is Robert, 65-year-old with Hep C, cirrhosis, well-compensated, has diabetes, CHF, varices, non-responder to previous antiviral therapy, but has not been treated with DAA yet. Drinks a couple glasses of wine, mildly obese, no ascites. The lab showed an INR of 1.1, biliary 1.8, platelet count 65,000, normal creatinine, AFP of 45.6. This is a MRI of the tumor. So on the left, there's an arterial phase, shows an enhancement in the tumor with some capsule. And then on the right is the portal venous phase, which shows some hypointensity and the delayed enhancement capsule and washout, has that characteristics for HCC. So this patient underwent 3 sessions of TACE and tolerated well. The bilirubin kind of remained stable. Had an MRI, and this is the MRI that the patient had. So there's necrosis of about 60% of the tumor, but there's still viable tumor left behind after the 3 sessions. Not a transplant candidate. So the question to the tumor board is, should we consider moving to systemic therapy or to another local regional therapy? And Laura, you first. So what do you think about this specific patient and what would be the next best step?
So In terms of continuing chemoembolization, this has been the same lesion that's been treated 3 times. Most people would agree that this is a failure, that there's not been a complete response. In terms of radioembolization, I think after 3 TACEs, it's unlikely. Those vessels are probably pretty beat up. We generally will do radioembolization first and then potentially leave TACE to kind of picket things afterwards. Its location may be difficult to get to for RFA. It does look like there's an area that you could potentially treat with RFA. There are ongoing trials that have looked at patients who have failed after 1 TACE and then done SBRT that looks promising, so I would consider potentially SBRT for this patient. And I think the consideration for systemic therapy is something to consider. So I would probably assess this person potentially for SBRT.
Richard?
Yeah, so this is a unique case because this is not a large tumor. This is a fairly small tumor. It's resistant to chemoembolization. In general, the flow is not resistant to chemoembolization, do more local regional therapy. In reality, in this particular case, it's fairly small. I'm sure our interventionalists could do RFA or try to do something like that. If they said there's nothing they can do, then I think certainly systemic treatment because the patient is still BCLCB, but they clearly are refractory to local regional treatment. SBRT is something to do. He can't go to transplant, so the goal is increasing overall survival. It's not improving his scan, right? And the only data, high evidence data here, is systemic treatment. You can always do things, but the purpose is not just to do, it's to improve OS.
So I'll just add one caveat. I think along what Richard said is that this is an area where we don't have level 1 evidence, right? I mean, it may be reasonable to even watch the patient because we've always aimed for a complete response with the assumption that this is going to translate to better survival. But whether that's really truly evident in a situation like this is unclear. So yes, SBRT is reasonable. I think switching to systemic therapy is reasonable. But in a case like this, if I'm switching to systemic therapy, I don't rush either in doing the
That's
switch.
a good point. I mean, the liver function is stable. I mean, has had some degree of partial response, I guess. So yeah, would you consider Y90, Laura?
Again, I'm not sure what the vessels are going to look like after you've had 3 chemoembolizations.
But what if the vessels are okay? That's a technical thing. What about data then?
Well, there's no.
So the vessels are
yeah.
okay. I suspect at Northwestern they'd probably do Y90 if they could.
If they could, yeah, they would try.
So one question that I'm going to ask to Anthony, why is immunotherapy detrimental to transplant candidacy? So Anthony and then possibly Laura.
Well, the reason is given the concern for rejection. There have been reports of rejection in patients with transplant who receive immunotherapy. It started in the renal transplant world, and that's why there's been an apprehension for that. So we really don't have safety. It's a safety issue related to rejection.
This is pre-transplant, which Laura, you made this comment.
Yeah, so there's no data on pre-transplant. We don't know how long these antibodies last. If you do it before you put the graft in, will it have any effect on the graft? But doing it before, there's this big concern of could you lose the graft? There has been some limited data looking at this post-transplant. Some people have had remarkable response after recurrent HCC. Others have died within 35 days of 1 dose of receiving Nivo. And the overall, again, very small numbers, but the overall graft loss in livers after checkpoint inhibitors is 36%.
Okay. So I think in the interest of time, we'll move on, and the other questions we'll tackle later. So now Richard Finn is going to talk about surveying rapid advances in target systemic therapy for HCC.
Well, thank you very much, Jorge, and thank you to PeerView for the invitation. It's always an honor to present to colleagues in another discipline. I've been very fortunate to be at UCLA, where I work with very talented hepatologists and surgeons and interventionalists. So for the past decade, the BCLC staging system, which is linked to data-driven recommendations for patients with advanced disease, has been sorafenib. And it's important to note, why do we stage patients? Well, it's one, so we can speak a common language within clinical research, but also so we understand the natural history of a disease and can make data-driven decisions. It's important to note that you can have advanced liver cancer and your tumor could still be confined to the liver. You don't need to have extrahepatic spread to be considered advanced. And prognostically, just having branch vein invasion is different than not having that. And I think Laura touched on that. And this slide actually just changed as pembrolizumab moved into the approved category. But in the past decade, and really only in the past 2 years, I would say, we've seen the approval of several new options in liver cancer: lenvatinib, regorafenib, nivolumab, pembrolizumab. And we have positive phase 3 data with ramucirumab and cabozantinib. And we'll walk through this data in the next few minutes. So this has been the backbone for which we have been trying to do better. You're very familiar with the SHARP and the Asia-Pacific studies, which were placebo-controlled phase 3 studies in advanced Barcelona C liver cancer, or, as that last case represented, patients who were Barcelona B or intermediate that had progressed on TACE. And this was placebo-controlled because at the time there was no intervention systemically that was shown to improve survival, and a very consistent benefit with hazard ratio of 0.69 in each. In the North American European cohort, that was about a median improvement in survival of 3 months, but that's a 31% decrease in the risk of death. And in cancer medicine, there aren't a lot of drugs that give hazard ratios in that range. So there's been a lot of different analyses of the SHARP and Asia-Pacific study over the past few years. These are retrospective, but some of them are based on the pre-specified strata. But it's important to note there's a consistent trend that patients who have Hep C-related liver cancer do better here 14 months, and I want you to remember that number. And also, looking at these patients who have no macrovascular invasion, no extrahepatic spread. So this is a group of patients who are probably Barcelona B. Their natural history was 14 and a half months. So these are still patients who do not have disease outside the liver. Perhaps that patient just presented. The toxicities from sorafenib are very well defined. The problem is we don't know who's going to get them, right? We give chemotherapy in the clinic, and we know patients are going to have alopecia, they're going to have nausea, they're going to drop their counts. With the newer drugs, the multikinase inhibitors, we know what could happen, but we don't know who's going to get it. The starting dose with this drug is 400 milligrams twice a day. It's dosed continuously. And really, the toxicities can be broken down into dermatologic and GI, with hand-foot skin reaction, diarrhea, anorexia being the common things in both the Asia-Pacific and North American European studies. So what did we learn from this? Well, this was the first time that we saw we could change the natural history of liver cancer after decades of nothing, very important. We learned what patients to select, and as you heard from Jorge and Laura, we're dealing with two diseases, liver disease and a malignancy, and the two play off each other. If someone has a bilirubin of 8 and has a cancer, we're not going to be able to improve their outcome, short of some transplant or something. But again, for patients to make an improvement in their cancer diagnosis, we need to find them when they're not going to die of underlying liver disease. And that's why this transition to earlier stage with systemic treatment is a trend we'll start to see in the future. As we have more drugs to get patients to second or third line, we need to get them to first line. And that's where the role of the hepatologist, I think, becomes critical in GI in screening and identifying patients. We're very comfortable managing these toxicities with dose reductions, topical emollients, but we still don't know exactly what sorafenib does in people. We know it hits the VEGF receptor and other intracellular kinases, but which one is most important, we don't know. And we don't know a biomarker, right? Cancer medicine has become precision medicine, right? We know in other diseases, breast cancer, if women have HER2 amplification, they're going to respond to antibodies and drugs towards HER2. With drugs like sorafenib, we have no way to select the patients who benefit. But we've been trying, and we've tried very diligently to do numerous phase 3 studies, and only until the past 2 years have we seen some positive data. With immunotherapy, as my colleague Anthony El-Khoury will discuss, really is approved now only on phase 2 data. So these are very complicated diagrams, and what you see here is a cell, and many of the targets for drugs are receptor tyrosine kinases, proteins that sit on the outside of a cell, get signals from outside, and then transmit to intracellular kinases and cause things to happen. We've been using drugs like this in other areas of cancer medicine for many years. Monoclonal antibodies, for example, to the VEGF receptor have been approved, or ligands like the vascular endothelial growth factor or other growth factors. And here in green are drugs that have positive phase 3 data in liver cancer, and many of them are very similar classes. They're multi-kinase inhibitors that hit several different proteins, and for some reason they work. But we can't pin down any exact mechanism. And Anthony will be talking about the immunotherapy aspect. So when we talk about the multi-kinase inhibitors, we have lenvatinib, which was approved a few weeks ago. It hits these targets, VEGF receptors, fibroblast growth factor receptor, which differentiates it from sorafenib, and FGFs have been implicated a lot in cancer biology, specifically in HCC, RET, KIT, and PDGFR. Cabozantinib, which has positive phase 3 study published in the New England Journal of Medicine on July 4th, hits not only the VEGF family, but also c-MET, the hepatocyte growth factor receptor, and AXL. Regorafenib, which is very similar to sorafenib in its VEGF receptor activity, but also hits other kinases important in angiogenesis. And ramucirumab. Unlike the other 3 drugs, ramucirumab is a monoclonal antibody. It only does one thing. All its toxicities can be related to that one activity of binding to the VEGF receptor. So the REFLECT study was the pivotal study of lenvatinib versus sorafenib, and this just shows molecularly the kinase profiles. And really, lenvatinib is a little more potent for the VEGF family, but really differentiates itself by its potency against the fibroblast growth factor receptor family. So the REFLECT study was a global phase 3 study that randomized patients to lenvatinib, which is dosed by weight. That's new for us, and that came out of phase 2 studies that showed in cirrhotic patients the PK of this drug is a little different, versus sorafenib 400 milligrams twice a day. I want to call your attention to a few things. Just like all the other phase 3 studies, it took patients who were Child-Pugh A, good performance status, Barcelona C or B post-TACE, but excluded patients who had more than 50% of their liver involved. It also excluded patients who had main portal vein invasion. None of the historical sorafenib studies did that. This was open label, geared for overall survival, but also this was non-inferiority. This was designed and powered to show that perhaps if they were non-inferior, defined by a very specific confidence interval, and if it met that, then they would look at superiority. The study was driven by mostly Asian accrual. 2/3 were from Asia, 1/3 from the Western population. I want to call your attention here that about 1/3 of the patients had no MVI or EHS. The majority of patients were C, but about 20% were Barcelona B. There were some imbalances. There were more patients in the sorafenib arm who had hepatitis C, and more patients in the lenvatinib arm had a higher baseline AFP. 2 things that could have favored sorafenib, right? Because patients with hep C do better with sorafenib, and a higher AFP at baseline might have hurt lenvatinib. Here we see the overall survival, 13.6 versus 12.3 months, and the hazard ratio here, 0.92, and the upper limit is 1.06, less than the predefined 1.08. And keep in mind, there were other drugs that tried to achieve this on that list that did not do that. Now, interestingly, and here using modified RECIST, that's like the EASL criteria. RECIST criteria in cancer medicine is a way to quantify response. And it looks at the total diameter, sum of the longest diameter of tumors that are target lesions. Modified RECIST takes into account that tumors in the liver that are treated with biologics might not shrink, but they lose their enhancement. And that might be important. So modified RECIST is looking at the length of the enhancing component, not the total length. Needless to say, by modified RECIST, lenvatinib essentially almost doubled progression-free survival. And time to progression was also markedly increased, 3.7 to 8.9 months. But again, this did not necessarily translate into a survival advantage, which is a challenge in studies. But Laura alluded to this data, and this was a central review done by Riccardo Lencioni, who is a very distinguished interventional radiologist. And I want to call it to his independent review. By modified RECIST with lenvatinib, the response rate was 41%. And by conventional RECIST, which is just the total tumor shrinkage, 19. For years, we've been telling you that response does not matter in liver cancer because it doesn't correlate with OS, and this might support that. But we've never had drugs that have high responses, and it might be changing as we move forward. And here you see sorafenib data, RECIST, single digit, 6.5%, a little higher by modified RECIST. Now, the toxicities of these drugs have some overlap. Both of them can cause diarrhea, anorexia, fatigue, very similar frequencies. However, hand-foot skin reaction is less common with lenvatinib, but hypertension is more common. And this relates, I think, to its potency against the vascular endothelial growth factor family. The RESOURCE study was the first positive phase 3 study since sorafenib. This was in second line and led to the approval of regorafenib, a very similar kinase, but a little more potent, as commented, than sorafenib. This study took patients who had documented progression on sorafenib, so more than 20% increase, and they had to tolerate sorafenib for a minimum period of time. This was placebo-controlled, as there was no drug that showed improvement in second line. These are the results. The hazard ratio was 0.63. These curves look very similar to the sorafenib overall survival curves. However, you see 7.8 months to 10.6 months, a 3-month improvement in overall survival. And the toxicity from this drug is not too different from sorafenib. Patients who got sorafenib, progressed, and then were randomized to this study and met all those entry criteria, had a survival of 26 months. That's a very big number for Barcelona C patients. And I'm not going to say this is everybody. This is strictly patients in a clinical trial population. But again, it highlights the point of finding healthier patients for systemic treatment. And then we look to say, well, did prior time on sorafenib, did that translate to the better outcome with regorafenib? And the answer is no. And here you can see the time to progression by quartiles, the first, second, third, and fourth quartile, so from shortest to longest period of time on sorafenib, and you can see the hazard ratios are very consistent. So you cannot use time on sorafenib to predict for benefit from regorafenib. And here again we have the toxicities, concentrating on the more serious ones, grade 3 or grade 4, certainly increased over placebo, but nevertheless, these are toxicities that I think many of us are familiar with: hand-foot skin syndrome, hypertension. Cabozantinib was presented at GI ASCO here in San Francisco at the beginning of this year and published, as mentioned, in the New England Journal of Medicine. And cabozantinib in a very similar design versus placebo. However, this was the first study that also included a third-line population, right? So about 25% of patients in this study had sorafenib, another drug, and then came on study. And here you see the overall survival in the total population from 8 months to 10.2 months, hazard ratio of 0.76. If we look at just the patients who were purely second line, like the regorafenib population, that hazard ratio drops to 0.71. And I would say these are very comparable data with regorafenib. And here you see those curves, 8 months to 10.2 months. And again, like we saw with Rego, even though we improve overall survival, we also improve PFS. And here, the toxicities with this drug are very similar to other drugs in the space: hand-foot skin syndrome, hypertension, diarrhea being the most significant. Ramucirumab is a monoclonal antibody to the VEGF receptor that was looked in a large phase 3 study that was negative. Negative, no effect. However, retrospectively, they looked and they showed that if you had a high baseline AFP, you get a benefit. So look at the control arms here. High AFP, 4.2 months. Low AFP, 7.6 months. So AFP appears to be prognostic. However, if you had a low AFP, really no difference in OS, and really the difference in OS, the benefit was in this high AFP group. So with that data, they repeated another phase 3 study. That's really unprecedented to do 2 phase 3 studies. The REACH-2 study was presented at our ASCO meeting a few months ago. It has not been published, but it was very similar to all the other studies in this space, but required patients to have a high AFP at baseline. So this was the first biomarker-driven study in liver cancer. And again, ramucirumab, it's IV every 2 weeks versus placebo. This study met its endpoint. We're still trying to tease this out. Here, the placebo arm did 7.3 months, right? I showed you before on the last slide, the high AFP group had 4.2 months. This met its specified endpoint, a hazard ratio of 0.71, very comparable to cabozantinib in a generalized population. Ramucirumab performed just as it did in the other studies, a survival at 8.5 months in this high AFP group. But this absolute difference of 1.2 months is a little less than we wanted to see, but there is somewhat of a tail to the curve. As you go out for patients alive a year and a half, 18 months, a quarter of the patients on the RAM arm are still alive versus only 10% on placebo. So we did a meta-analysis and combined the high AFP group from the first REACH study with the AFP group from REACH 2, and here the control arm looks a little more like expected and went from 5 to 8 months, a difference of 3 months, hazard ratio 0.69, very similar to what we saw with other drugs. And again, we can improve progression-free survival. And this is consistent across all these clinical subgroups that we've looked at. But again, unlike other drugs in its class, pure VEGF inhibition, it's not driven by response. It's driven by slowing tumor growth. And keep in mind, because I know in clinic we get obsessed with imaging, right? But imaging isn't the most important thing in improving overall survival. It's looking at the whole patient, their performance status, weight loss. These are very important predictors. This drug is safe. It's a monoclonal antibody, so its toxicities are related to the VEGF interaction, and so we see a little more peripheral edema, fatigue. There was an increase of ascites with this drug, but generally manageable. And again, we expect that to be approved. EASL guidelines, which were updated this year, probably before we had several of the studies read out, clearly have systemic treatments, sorafenib, lenvatinib, rego, cabo, and presumably we would have ramucirumab there if it had read out that time. Very strong, high-level evidence for use in patients with advanced disease. And Jorge showed this earlier, again, updated with all the new data. So we're making progress in liver cancer, and there's been a robust amount of progress in the last few years. And, these are incremental improvements, but I think we're seeing, certainly from the regorafenib's experience, that sequential improvements in OS will hopefully change the natural history of this disease. And now that we have other drugs that we can sequence, there's no point in doing research if we don't apply that research to the patients we're treating. And still, there's a lot of challenges. We need to identify the right patients for systemic treatment. Hopefully, we could do that with some biomarker in the future. But right now, we're based with clinical characteristics. We need to identify, using better imaging maybe, how we know which patients really benefit. Is it M-resist or resist? And ultimately, we need more drugs and better therapeutics. And again, I think what we're going to see now as we sequence more agents, we will be changing the natural history. Thank you very much for your attention.
So we're going to present a case and TKI options for HCC. Henry is a 63-year-old gentleman with hepatitis C, diabetes, good performance status, drinks a glass of wine a day, non-smoker, has really no weight loss, no ascites. The labs are presented, normal renal function, INR 1.1, albumin 3.8, bilirubin of 0.5, pretty good healthy platelet count, and an AFP of 6,500. This is a scan. This is arterial phase. There's a hypointensity here, a large mass involving pretty much most of the left lobe. And in this cut, we see the main portal vein is involved with a tumor. A biopsy was performed, and the HCC was confirmed. Rich, what is the first-line agent for this gentleman? Child's A, portal vein involvement, large tumor.
This guy has platelets of 175, which we don't see so often,
Correct.
well compensated. The answer is a clinical trial, okay, and that's a default. But it's very important for all of the hepatologists. The only way to move forward is to refer these patients for clinical trials. With that being said, evidence would suggest sorafenib or lenvatinib would be acceptable options. Some of the things, and I will relate to one of the questions here, by level of evidence, all of the phase 3 second-line studies were done prior to lenvatinib, right? So they're all done after sorafenib. So do they work as well after lenvatinib? Technically, I can't tell you that, right? Because they haven't been asked that way. But I think we would make the assumption that they're proven to be second-line drugs and that the front-line option might not be so relevant. But sorafenib or lenvatinib, that would be my answer.
Anthony?
No, I fully agree. I don't think we have a way to choose one or the other
At the moment, yeah.
At least with this case. You know, there are probably other cases where we could.
Okay, fair enough. So we continue. Sorafenib was chosen, started at 200 BID, and then escalated to the full dose of 800 daily. Tolerated for quite a few months, and then a repeat MRI to assess the response was performed, increased to 9,700. So the MRI did show an increase in the number of lesions as well as the AFP elevation. So now the question is, sorafenib was chosen as the first line. Do we continue sorafenib, or do we go to another agent? Richard?
A rising AFP alone, I would not change treatment, right? If the imaging remains stable, I think it's a harbinger of future progression. But this patient has clear radiographic progression before sorafenib. And just like before we had systemic drugs, the reason we do TACE is because we had nothing else to offer them, right? Similarly, if we only had sorafenib, we would say we'd continue it. He doesn't have clinical progression. But now he has radiographic progression, right? We can't wait until he clinically decompensates because then he won't have the option of other treatments. So the highest level of evidence for the approved drugs would be for regorafenib. That's based on phase 3 data. Nivolumab and Pembro are very provocative drugs and look very active, and Anthony will answer that. I think for me, I might choose regorafenib for this patient, and part of that discussion is, will they live long enough to get another option, right? This guy has progression, presumably his labs are okay, he's still active.
They are.
You know, he probably will get a third-line option, which would be one of the checkpoint inhibitors, but I would probably go with rego.
So Anthony, I'm going to put you on the spot. So what if first line was lenvatinib, and now now he has tumor progression on lenvatinib? What second line would you choose?
Well, as Richard alluded to earlier, it is unclear whether the subsequent lines of therapy will have the same outcomes post-lenvatinib or not. So we don't have the data. So I think all of these options remain reasonable post-lenvatinib at this point without any other evidence. I agree that this patient meets the resource trial criteria for entry, tolerated sorafenib, did well, and that's the level 1 evidence with phase 3 data. As Richard alluded to, I think the immunotherapy, the main benefit there seems to be with those patients who have these deep, long-lasting responses. And that's why everyone feels like we need to give the patients a chance to be exposed to the immunotherapy. So as long as they're able to make it to third line.
So now, back to the last talk of the evening, understanding the full potential of immuno-oncology approaches in HCC, and Anthony Alcuri. Thank you, Anthony.
Thank you very much. It's a pleasure to be here. So in cancer, immunotherapy has become the hardest area of cancer therapeutics over the past few years. And this is based on the evidence that tumors use a complex set of mechanisms to evade and suppress the immune system. Many of these that are listed here in this schematic have been actually documented to be present in hepatocellular carcinoma. There is ineffective presentation of tumor antigens. There is recruitment of immunosuppressive cells, T regulatory lymphocytes, myeloid-derived suppressor cells. Actually, there is some association with prognosis. The higher the T regulatory lymphocytes, the worse the prognosis post-resection. There is upregulation of the inhibitory checkpoints like PD-1, CTLA-4, LAG-3. And then there is release of immunosuppressive factors, some of which are listed here, TGF-beta, IDO, IL-10. So there's evidence also, but this evidence is mostly from resected HCC studies where the balance of T regulatory and cytotoxic activated T cells does matter and is associated with prognosis. Patients who have low regulatory T cells, high cytotoxic activated T cells do better than the opposite. Similarly, there's been some association with outcome and PD-L1 expression. So high PD-L1, high PD-L2 have been associated with worse outcomes as would be expected in this tumor type. So with that, the efforts to evaluate checkpoint inhibitors in hepatocellular carcinoma were launched over the past several years. And in the schematic of the T cell on the right, you see these inhibitory checkpoints. I call them the brakes. These are the ones that stop the T cell from being effective at achieving anti-cancer immunity. And we'll talk tonight about anti-PD-1 and anti-CTLA-4 inhibitors. These are the ones that are furthest along. But there are other targets that are actually under evaluation as well to invigorate the T cell effect on the tumor. On this side are the stimulating agents. These are the gas pedals. So in theory, these are agonists that will actually, again, invigorate the T cell to achieve more anti-cancer immunity. Some of the ones that are being evaluated in HCC include OX40 and CD137 as examples. The concept of checkpoint inhibition is that preventing the interaction between PD-1 on the T cell and PD-L1 on the tumor cell will unleash the potential of the T cell and lead it to achieve anti-tumor effect. I'll first cover the Nivolumab data with Checkmate 040. In this study, we had two parts to the trial. There was a dose escalation phase and an expansion phase. In the dose escalation, there were three parallel dose escalation cohorts: uninfected patients, Hep C infected, Hep B infected. The reason that was done because there was no safety data prior to this looking at checkpoint inhibition, especially anti-PD-1 inhibition, in virally infected patients. And in a nutshell, what this showed is that the safety profile of nivolumab was the same in HCC as in other tumor types, and the recommended phase 2 dose was the same as we use in other tumor types, 3 milligrams per kilograms, and later that's been translated into the fixed dose of 240 milligrams, actually. Then there were 4 expansion cohorts that are listed here. 2 of these were in uninfected patients, so a group of patients that were sorafenib naive or intolerant, sorafenib progressors, then Hep C infected, Hep B infected. First, let me cover the baseline characteristics, and I'm using the expansion population here grouped all together, all 4 cohorts. And you see some important highlights here is that 75% of the patients had extrahepatic metastases, 7% had vascular invasion. The large majority were Child-Pugh A, 5 or 6, very few Child-Pugh B. And these were heavily pretreated. A little more than half had surgical resection, some radiotherapy, local treatment 59%. Importantly, 73% had prior systemic therapy and 66% had prior sorafenib. And when we group all 4 cohorts together, the overall response rate based on RECIST 1.1, this is not modified RECIST, was 20%, with some complete responses here that are seen, and I'll show you then the durability of the responses later. 45% of patients had stable disease. You see here about a third of patients had progressive disease. Now, if we look across the etiologies or across the cohorts, you see that the responses happen independent of etiology. There were responders who were Hep C, Hep B, uninfected, and irrelevant of line of therapy. Now, there are some minor numerical differences, but the numbers are small, and these are not powered for comparison against each other. This slide highlights 2 points. In the spider plots, you see that they appear the same for all the various groups: Hep C, Hep B, uninfected, sorafenib progressors, or sorafenib naive patients. This is meant to highlight the durability of the responses, but this is better shown here. Let me draw your attention to this first here. These are the sorafenib experienced patients in the expansion cohort, and you see that the median duration of response was 17 months. So the patients responded, and the response lasted for a long time, and the responses happened early. the median time to response was between 2 and 3 months, no matter what group we looked at. Similarly, for the sorafenib naive group, the median duration of response was 17 months, and the median time to response, 2.7 months. What about survival? Again, this is a single-arm study, so there are some limitations to that. But there were about 80 patients who were sorafenib naive. If we put the patients in the dose-finding part of the study and the expansion part together, 80 patients were sorafenib naive, and their median overall survival was 28.6 months. For the sorafenib experienced patients, their median overall survival was 15 months. These were about 150 patients or so. What about tolerability? If I draw your attention to the far right column, if we look at grade 3 and 4 events, treatment-related events, 18% in total, and you see that these were classic for what we see with checkpoint inhibition, diarrhea, some nausea. It's quite rare actually, but if you look at all grades, you see the pruritus, rash, which again are expected with checkpoint inhibitors. And then if you look at liver abnormalities here, the rate of grade 3 and 4 ALT, AST elevation was quite low. So with this, nivolumab received accelerated approval post-sorafenib in patients with HCC. This is now pending the completion of Checkmate 459, which is a randomized phase 3 trial comparing nivolumab to sorafenib in the first-line setting in previously untreated patients, no prior systemic therapy with HCC. Similarly, the data that we saw with nivolumab have been validated with the recently reported data with pembrolizumab, another anti-PD-1 antibody that just received approval, another accelerated approval. This was based on Keynote 224, a single-arm phase 2 study, about 100 patients, as seen here, who were previously treated with sorafenib or were intolerant to sorafenib. And the primary endpoint was response rate, and the objective response rate here was 17%. Again, very comparable to what we saw with nivolumab. And again, these responses were durable, as seen here, as far as patients remaining on therapy and having a response. Similarly, we are awaiting the phase 3 data of pembrolizumab versus best supportive care as second-line therapy. This is post-sorafenib. So 2 pending phase 3 studies with anti-PD-1 agents. As a reminder, despite the fact that these are well-tolerated agents, one has to be aware of the very serious immune-related adverse events that could occur, and that could involve literally any organ system in the body: endocrine, respiratory, gastrointestinal, etc. I think the most common that we see are colitis, probably followed by pneumonitis. Certainly, we see AST and ALT, AST increases. I can tell you in the nivolumab experience, we did a handful of biopsies, and none of these showed the typical autoimmune hepatitis features. But some of these patients did respond to steroids as far as bringing down their AST and ALT. So one has to be cautious about these potential complications and has to intervene appropriately. So if they're very mild, grade 1, you can continue immunotherapy and watch the patient. With grade 2 events, the immunotherapy needs to be withheld, and usually corticosteroids need to be started after at least a week of watching the patients. And that the corticosteroid taper has to be slow, has to be over a month or longer. For grade 3 and 4 events, usually immunotherapy needs to be discontinued and not resumed, and the patients also need to be treated with immunosuppression, usually starting with corticosteroids. What about other checkpoint inhibitors? We talked about anti-PD-1 agents. What about anti-CTLA-4? This study done by Bruno Sangro in Spain with tremelimumab, an anti-CTLA-4 antibody, was done before the nivolumab data. It was a single-arm study that looked at tremelimumab as a single agent in Hep C infected patients. They were Child-Pugh A or B, and they were not candidates for locoregional therapy. And the primary endpoint was tumor response. And the first message from the study is that treating patients with CTLA-4 agents was feasible. except here that you see slightly higher rates of AST and ALT elevation that are grade 3 or higher with CTLA-4 therapy. But some of these patients were Child-Pugh-B patients, so they were slightly sicker. But it was feasible. And similarly, there is a response rate of almost 18%, a disease control rate of 76%. Median OS here is at 8 months, but again, the fact that about 30 to 40% of these patients were Child-Pugh-B did impact that number. Interestingly enough, there was a statistically significant decrease in hepatitis C viral load with anti-CTLA-4 therapy. Now, Dr. Kulik mentioned this study earlier. This is combining an anti-PD-L1 antibody, durvalumab, with anti-CTLA-4. And this was a small phase 1b study looking at durva as a single agent, tremi as a single agent, or the combination. And here I want to show you the data from the combination where the confirmed response rate was 18%. So not very different than the single agent anti-PD-1 or anti-CTLA-4 therapy, but nonetheless intriguing. If you add the unconfirmed responses, that was 25%. Nonetheless, based on this, the Himalaya trial is ongoing, and I'll show you this in a bit. But what's interesting also that combining anti-PD-1 and anti-CTLA-4 therapy was feasible. Looking again at grade 3 and 4 events, there was more frequent AST, ALT elevation, but this was all manageable and usually reversible with interruptions or with steroid therapy if needed. This is the Himalaya trial. This is a phase 3 study that's ongoing, randomizing previously untreated patients with systemic therapy to durvalumab alone, 2 different doses or 2 different regimens of the combination of PD-1 and CTLA-4 versus sorafenib as the control. Primary endpoint of overall survival. Similarly, in the Checkmate 040 study, we reviewed the data from the nivolumab single arm part of the study, but there is actually a completed nivolumab plus ipilimumab combination that hopefully will be presented in 2019 as well. And there is a triple combination of nivolumab plus minus AP plus cabozantinib that will also be reported hopefully next year. Also want to spend a minute saying that immunotherapy is not only about checkpoint inhibition. There is vaccine therapy, there is cell therapy, and many of these studies are ongoing in early phase trials at the moment. There's also a very sound rationale for combinatorial therapies, and Dr. Kulik mentioned some of this in her talk a little bit. There is good rationale for combining checkpoint inhibitors with targeted therapies because the targeted therapies have been shown to upregulate the Treg population, maybe increase PD-L1 expression. Similarly, there is rationale to combination with locoregional therapies because the effect of locoregional therapy with cell necrosis leads to higher antigen presentation and potentially tumor-specific T-cell responses. Here is some early data from these approaches. This is a study combining pembrolizumab with lenvatinib. And again, early data, 30 patients. You see the tolerability here, that if you look at treatment emergence events, every patient had them, but if you look at the treatment-related events, they were quite frequent. But when it's broken down, this is still a feasible therapy when you look at the details of grade 1, 2, and 3, and 4 events. And if we look at the responses, this is by modified RECIST. This is not by RECIST 1.1. If you look at the confirmed response rate, it's about 27%. If you look at the entire, including unconfirmed, it's 42%. So intriguing signal, early data, we will see how this evolves. Similarly, a combination of atezolizumab, an anti-PD-L1 antibody, with bevacizumab, which is an antibody against vascular endothelial growth factor. Similar rationale. This was part of a large phase 1 trial targeting multiple tumor types, but they had an HCC cohort in that study. And they just recently presented at ESMO 2018 the results from 103 patients. Again, you see the grade 3 and 4 events. The hypertension is driven by the bevacizumab, and these are the events more typically seen with anti-PD-1 therapy, with atezolizumab. But this is the number that everybody's been looking for. The overall response rate was about 30% with this combination. When it was done by independent review, it was 27%. So it's somewhere in that range, similar to what we saw with pembrolizumab lenvatinib. And again, we are all looking forward to see how this data evolves and if it translates into a survival benefit or not. Combining tremelimumab with locoregional therapy is, again, something Dr. Kulik mentioned. This was the study done at the NCI by Tim Gretton's group, where they did partial ablative therapy using either partial TACE or ablation combined with tremelimumab. And the proof of concept is this increase in CD4 and activated CD8 T cells, even in non-treated tumors. Again, indicating the potential benefit of this combination approach. Going back to the fact that immunotherapy is not only about checkpoint inhibition, this phase 3 data is from a Korean trial that took patients with mostly hepatitis B-driven HCC and largely early tumors treated with resection, ablation, or ethanol injection. And these patients, post-resection, they had autologous cytokine-induced killer cells expanded ex vivo and then reinfused into the patients. And you see here that the recurrence-free survival was significantly improved with this approach, and so did the overall survival. This, of course, needs validation in larger and other groups of patients, but nonetheless intriguing. Ongoing is an adjuvant study also looking at nivolumab post-resection. This is now recruiting patients, and it's trying to select patients that are slightly higher risk, and they're being randomized to nivolumab versus placebo post-resection, since there is no standard of care in this setting. In summary, checkpoint inhibition, especially anti-PD-1 therapy with nivolumab and pembrolizumab, has shown favorable safety and early efficacy in HCC. The challenge is how to expand this benefit to more patients, potentially with biomarker development, so we can really know which patients will mostly benefit from this therapy and minimize unnecessary exposure. The future is in combination therapies, both immunotherapy combinations, immunotherapy with tyrosine kinase inhibitors, or locoregional therapy. At this meeting, you will see the cohort of Child-Pugh-B patients treated with nivolumab. This will be reported for the first time. And we're more and more going to be exploring combinations with other current standards of care, including locoregional therapy. Thank you very much.
Thank you, Anthony. Now we're going to go to a case consideration of with immunotherapy in HCC. This is Helen, 59-year-old, Hep C, well-compensated, hypertension, well-controlled, never underwent antiviral therapy, has varices but no encephalopathy, no alcohol, non-smoker, has some weight loss, no ascites. The labs look pretty good at bilirubin of 1.7, albumin 3.5, INR 1.2, a platelet count 112,000, and the AFP is 2,900. This is a scan, so it shows a pretty bad tumor, mostly involving the right lobe. This is a main portal vein involvement and has lesions in the left lobe. So this would be a BCLC stage C patient. The patient is initiated with sorafenib. She's stable disease after 5 months of therapy. Then basically on the scan at 6 months develop an increase in the number of lesions, more than this. Then nivolumab was started every 4 weeks. After the third dose, these are the labs. ALT of 257, AST 254, and an increase in the bilirubin of 2.8 from 1.7 at the start of the therapy. Anthony, how you manage this adverse event probably related to the immunotherapy?
Well, I mean, this is a difficult area because to determine whether it's really related or not, I can tell you that in the checkpoint inhibitor studies with nivolumab, The patients with hepatitis C infection had a higher rate of AST and ALT increases compared to non-Hep C patients. So some of this may be actually related to the underlying disease. It's unclear. Nonetheless, in this patient, unless there is frank progression to explain these numbers, you would have to treat it as a potential hepatic-related, immune-related event. And in this case, actually, this would meet grade 3 criteria, because if the AST and ALT cutoffs are around 40, this is more than 5 times normal. So this would be grade 3 event. You would need to discontinue the treatment, actually, and initiate steroids. For grade 2 events, you can hold, initiate steroids, and then resume, of course, as it says here on the slide. But for grade 3 events, usually we do not re-challenge these patients. Mm-hmm. I can tell you again from the experience, some of these patients have these initial increases that are self-limited. So sometimes if the patients had grade 2 events, we watched them for about a week. If the numbers came back down, we did not initiate steroids, and they were actually doing okay. And some that continued to increase.
In this case, the bilirubin is what's concerning to me,
yes.
Right? The 2.8. And it also depends where his enzyme started, or her enzyme started, right? And Anthony is very familiar with this. But the label for Nivo and Pembro has a whole algorithm, because the liver patients are treated different than the other indications, and it all depends on where they start, how much they rise, et cetera.
This case, actually, we got a liver biopsy. And because of the Hep C, we didn't want to do the steroids without it. But it was all the autoimmune flare. And she was treated with steroids and actually had a good response with improvement in the bilirubin. I'm just going to start looking at the questions that we got from the audience.
As Dr. Finn showed, a recent analysis of the REGO study demonstrated this overall survival of the sequence of sorafenib and regorafenib was 26 months. Does that mean that we may be moving systemic therapies up front to BCLC-B patients in the near future? After all, median OS for BCL-B is about 26 months. I'd say not without definitive data. I mean, patient selection will determine how long patients live. And if you select Barcelona B with this combo, they probably do even better than 26 months. But I appreciate the question, and again, speaking to people trained in internal medicine, I think we think differently than people who do procedures, and we are data-driven. And I think if the immunotherapy trials confirm these high response rates, I would argue the next studies are to challenge TACE and BCL-B, because we're seeing response rates with some of these combinations of 40, 60%, which is what you see with TACE. Yeah. It's a hard study to do, but it'll take commitment, and it'll generate high-level data.
But this speaks to what Richard brought up earlier, which is the importance of making the switch from local regional therapy to systemic therapy in a timely fashion, ultimately.
Correct. And this is why the multidisciplinary tumor board is so essential. We as hepatologists need to rely on our oncology colleagues and IRs and everyone. Question, how long do you treat with sorafenib before reassessing response and switching to Rego? Anthony.
So we're oncologists. Now that we have subsequent lines of therapies, I do restage patients every 2 months once they start systemic therapy. And I switch when they have radiologic progression.
What is that, right? I mean, because I think we want to give patients the benefit of the doubt of first-line treatment. So, a new lesion, not just a 2 millimeter thing. Radiologists sometimes overcall things. So absolutely. A lesion that's growing, that's real, a new portal vein clot. A radiologist will say lesion went from 8 centimeters to 8.4, consistent with progression. To me, that's error. Right?
Yeah. A good point. Rich, the case that you had that had main portal vein involvement, would you offer TARI for that patient instead of sorafenib?
Main portal vein invasion, most will back off. Yeah. It's the branch portal vein where I think we start having some active and lively discussions, because we have very high data that we just went through with all these new drugs, level 1 evidence, and it's lacking with Y90. Now, Y90 is a procedure. Some people say, oh, you do it once, and then they can go to systemic treatment. Question is why, right? Why do it? I don't know. That is, certainly if a patient's a clinical trial candidate, I would not entertain that, right? That always is our goal. But even off trial. I think there's just very high level evidence to do systemic treatment.
So now there are 3 total studies of head-to-head of Y90 versus sorafenib.
Oh yeah, that's a very good point, right? There's been now negative phase 3 studies, right? SARA, Ceramic, and Survanib, all negative.
It was a resin type of Y90 delivery instead of the beads. So, I think we're waiting for that study.
Just do it right
Yeah.
and show me.
Yeah. So the next question, do you consider stable disease a good outcome in newly diagnosed HCC patients on upfront TKI? Anthony.
Well, again, many of the TKIs are considered cytostatic agents. And we learned that with sorafenib, that the prolongation in survival was driven by stabilization of disease, not by response. We also have had multiple examples of improvement in response rate that did not translate into overall survival. So disease stabilization does remain important in anti-cancer therapy.
I'd like to flip it though. What about with IO, right? You commented that, the TKIs,
Right.
that's how they work, but what about stable disease with nivolumab?
So that's where we need the phase 3 data to know with checkpoint inhibitors whether the benefit is all driven by the responders who are very deep and long-lasting responses versus also the stabilization of disease. And without phase 3 data, we cannot say that.
So the next question from the audience is, any BCLC-B patients whom you would consider ideal candidate for a trial with local regional therapy plus some systemic therapy?
If they qualify, then yes,
Yeah.
right? It's because think of it this way. Clinical trials are so hard to enroll, let alone in liver cancer where they have to be Child-Pugh A, platelets, XY. It's such a small percentage of the overall patients we see that you have nothing to lose to putting patients on clinical trials. To treat a qualified patient outside of a trial is, I think, a crime.
Now we know how you feel. So the last question from the audience is, can you foresee or avoid biliary complications with radioembolization? I think it depends on the tumor location and the selectivity and the skill. And this is where the operator may be a difference in someone like Riyad Salem at Northwestern, who's really experienced. Then I think in those kind of experience, then they can avoid such complications. But if the tumor is near the gallbladder, I think that would be very difficult. So anything you want to add?
I think biliary obstruction, if they have Bill on the scan,
Exactly.
a stent.
That's right. So I think that's it. Thank you for your attendance and participation. I think we reviewed the spectrum. So thank you very much for your attention and good night.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/WDR. This educational activity is supported through medical education grants from Bayer Healthcare Pharmaceuticals Incorporated, Bristol Myers Squibb, Ation Incorporated, and Exelixis Incorporated.